left ventricular outflow tract obstruction problem, and it's just a problem with the aorta itself, aortic stenosis, and depending on just where the constriction is taking place, it's going to be classified as either subvalvular or valvular, or, well, one of these is supposed to say supra. If we're going to say right above the valve, the aortic valve, right at the aortic valve, or right below the aortic valve. So let's call this supra here. Now, just like with pretty much all of these problems, it could depend. It could be a minor case or it could be a pretty severe case. So in the event that it is a pretty severe obstruction, then we know that cardiac output is going to be greatly affected, and that could lead to cardiogenic shock, as well as, of course, hypoperfusion, which will lead to your metabolic acidosis. And what do you do for this kind of problem? They can give artificial prostaglandins, and that will help to dilate the vessel as far as to support the cardiac output, to try to help to get it up. The inotropic agents would be helpful. And mechanical ventilation, that we know is going to affect your pulmonary vascular resistance. Positive pressure ventilation, especially when you start adding PEEP, will cause your PVR to increase. And that's something, well, no, let's just say that CMV is something that's going to have to probably be used to support the child if there's definitely an issue as far as, not being able to maintain adequate cardiac output and et cetera. So what they could do is, this is also something that could be kind of a minor surgical procedure. They can go in and do what's called a balloon valvotomy. And it's almost like a pulmonary angioplasty. When you've got somebody who's got coronary artery blockage, and they go in with the catheter with the balloon, and they inflate the balloon to try to open up the blocked passageway again. But with this balloon valvotomy procedure, they will go in, and then they will leave this stent behind, so that way you've got area that's now reopened to blood flow again. All right. Now, coarctation. Let me see if there's anything else that we need to say about this. This is just the aorta that's being affected. And I'm looking at what's included on this picture here. Yeah, that's all we really need to say about this, is that you will have to go in and reopen the blocked area, is what it essentially comes down to. Now, coarctation of the aorta. So again, now we're looking at a constriction, but instead of the problem being around the aortic valve, this is a problem that's near your ductus. So once again, it could be a narrowing that's taking place right before the ductus, right at the ductus site, or it could be a little bit further down from the ductus. And either way, you're going to end up with a much, much higher afterload on the left side. And we know any muscle that works harder it's going to get larger. So you're going to possibly see some left ventricular hypertrophy, and things are backing up. So you've got like the classic like CHF kind of issue or pulmonary edema. And so what we would see, if you're going to see anything at all, would be, say, like if it's a really bad case of coarctation, then you start to see these differences in blood pressure as far as the upper extremities versus the lower extremities. Somewhere around, I think they say 20, a difference in blood pressure between the upper and lower, around 20 or so, is going to be significant. And that would lead you to believe that the ductus has closed. And if the ductus remain open, then that's going to kind of help the child. So that way blood can still make its way past that constriction, especially depending on exactly where the constriction is. But if the ductus just decides to close, then that's where you're going to now probably see these regional differences in blood pressure. Now, what do we do for this child? So you can give them something to kind of open up the ductus. If the ductus hasn't already opened on its own or starting to close, then we have to give some kind of prostaglandins to kind of help to reopen that ductus again. And then again, because of the problems that you have with all like the CHF, pulmonary edema, et cetera, we're going to be thinking diuretics is the best bet, as well as the inotropes to help support the cardiac output. And then if they require it, then you're going to have to do surgery. And with these surgeries, the babies are usually, or the children are usually okay afterwards, meaning that they don't have to really be on the ventilator for like long periods of time unless there's some other complication. So what we'd expect to say is that a child essentially had to be intubated for the surgery or the surgical procedure. And then after surgery, they're probably still going to need to be on the ventilator for at least about a day or so. And then they could be possibly extubated without any issues. So in other words, almost like any standard post-op kind of case where you've got someone who is still on the ventilator, but they shouldn't be on the ventilator for a long period of time. It's just a matter of just giving them a chance to wake up, or in these cases, just making sure that everything is okay before you decide to extubate. Now, HLHS, or hypoplastic left heart syndrome, this is like an umbrella statement because it could be many things going on in this problem. It could be something that's just a problem with the aorta itself or the aortic arch. It could be the left ventricle is the problem. It could be the mitral valve. I mean, it could be, again, it could be so many. It could be one or two. It could be multiple. And no matter what, with this kind of a problem, your foramen ovale needs to be open. Because if it doesn't open, then the child would probably not survive. Now, because of the issue that's going on with the left side of the heart, then that means that they refer to this as like a, how do I say, parallel. The circulation between the right and the left side is in parallel with each other. But that's only because of the foramen ovale being open. So in this picture here, it's pretty noticeable that they're saying that underdeveloped left ventricle. So look how small that ventricle is. And all of this is just muscle tissue here. So that left ventricle has definitely hypertrophied. And And then they're also showing that there's possibly something that's going wrong with the aortic valve. So now here's our foramen valley that's open, so that way you can get blood to go from the left side to the right side of the system. And then also your ductus is also going to help as well. So with HLHS, this heart is going to need all the help they can get as far as shunts. It's going to need to have your foramen valley and your ductus open. So some blood is shunted through the ducts. Of course, this is again what needs to happen, so that way you can get pretty close to like a 1-to-1 ratio between your pulmonary blood flow and your systemic blood flow. So your QP-QS ratio would be maintained at somewhere around a 1-to-1. As far as our drug therapy options, we can again give the prostaglandins to make sure that the ductus stays open. So the more prostaglandins you give, now again, the body will produce its own prostaglandins, but in these cases, you're going to need more to make sure that that ductus stays patent. And then subambient oxygen therapy, that's something that they could do to cause your pulmonary vessels to constrict. And if you constrict your pulmonary blood flow, or you constricting the vessels on the pulmonary side, then that's going to help to also support that balance of flow between the right side and the left side of the heart. And there's also a couple other things that they can consider. They can just give like carbon dioxide. They could take some carbon dioxide and deliver it. Say if you got the patient on the ventilator, you can pipe in carbon dioxide, or you can connect it in line with the ventilator. And let's see, I'm going to write other options here. I'm just going to call it CO2 therapy. And then they could also, well, they can also do kind of like a version of permissive hypercapnia. But we don't really call it permissive hypercapnia here. We're just going to say purposefully hypoventilate with your vent settings. So it's kind of like the same thing as like CO2 therapy, because this could be a little bit complicated to deliver the carbon dioxide, but you could always just adjust your vent settings so that way your CO2s are going to be higher than usual. And what else could we do? We could definitely do CO2 therapy. We could hypoventilate. And then, of course, if all else fails, then we could definitely, they would have to be scheduled for surgery to fix it, especially if it's like multiple issues. And it's not just like, say, it's not just the aortic valve that's being affected that's causing the obstruction to blood flow, or it's not just that the left ventricle is the problem. So they would have to probably go in and do some surgery. It would require probably like multiple surgeries as well. Okay, and this other, now we're looking at the others. So again, those other tract flow obstructions I mentioned, early in the beginning where I posted to our chat link, we're not going to get into those. We're just going to pretty much just focus on like the HLHS and the and the aortic stenosis and the coarctation of the aorta as our left tract flow obstructions. Now this section right here, the other cyanotic lesions, and of course the tetralogy of Fallot. The tetrad here is the problem with the pulmonary artery being narrower. There's a hole between the right and left ventricle, which is our pretty much our ventricular septal defect. The aorta, the overriding aorta. So your aorta is not really opening up where it's supposed to. So where's our aorta? So here's the aorta, and this opening is so close to that septal defect. So that's why they're considered to be an overriding aorta. So all that mixing that ends up taking place here, and then the blood is now trying to leave the left ventricle through the aorta, and the aorta is in the wrong place. And then the right ventricle itself is working harder because you got all this extra blood that's shunting over to the right side, which means almost like an overflow of blood on the right. And that ventricle now is experiencing a whole lot more blood volume than usual. So it's going to have to work harder. So that means that we could look at this as being like a definite increase in right afterload. And that muscle gets larger. Now, so the ventricular septal defect, as it was mentioned earlier, there could be, my goodness, it could be a mild case or it could be a worse case, meaning that it could be like a restrictive or like a non-restrictive, essentially, kind of problem. And if it's mild, then that's when it usually presents as like a left to right type of shunt. But if it's a larger opening, then that's when you could see the shift in the shunt. It can go from instead of left to right, it can be a right to left. And we can't really use skin color to guide us anyway with a lot of these cardiac anomalies. I mean, we could generalize and say that if the blood is shunting from the right side to the left side, then the baby would probably present as cyanotic. But if it's going from the left side to the right side, then they usually are pink and they don't really have that much cyanosis. But it could really depend. It really, that's why we don't ever want to just say always expect, because there's always exceptions and it happens all the time. So when you expected to see cyanosis, you didn't see any, but the baby's still deteriorating. Or if the baby, you expected the baby to be acyanotic or pink, but yet they're as blue as a blueberry. And with tetralogy of Fallot, they probably will need to, if the ductus hasn't already naturally reopened, they're probably going to need to get some Indocin or something to get it to open up again. I'm sorry, not Indocin, but get some prostaglandins to get it to reopen again. And in most cases, they may need to get surgery. And as far as X-ray, what is significant, and the MBRC will sometimes check to see if you recognize what a boot-shaped heart would mean on a child's X-ray. And this classic kind of a shape is usually what happens in TOF. So this other cyanotic problem here, or other cyanotic lesion, transposition of the great arteries. It used to be called transposition of the great vessels, but still the same problem, just however you want to describe it. So with this, something definitely didn't go right as far as when the fetus was developing. And you know, the heart is one of those first organs that's going to get started very early. And some gene did not code correctly in that development process. And when that happens, then you get something that's completely odd like this, where you got your pulmonary artery. Your pulmonary artery is opening up at the left ventricle, and your aorta is opening up at the right ventricle. And as you can see, everything is practically purple to represent mixing of oxygenated and deoxygenated blood. So on the right side of the heart, all of the blood is returning back like it was supposed to from the upper extremities and the lower extremities. And then once that blood is passed through, well, it's purple because your foramina valley is open. And it has to be open because otherwise you wouldn't survive like this at all. So here's that deoxygenated blood that's now getting a chance to get mixed with the oxygenated blood that's coming from the left side of the system. And now here it goes, and now it's on its way out to the body. But it's mixed, so it's not fully saturated. And then when we think about what's going on the left side of the system, so some of this blood ends up going, let me draw another color here. Some of it ends up going through your ductus arteriosus. So now with this blood going through the ductus arteriosus, it will make its way out to the lungs. So that's how it's going to participate in some gas exchange. So when that happens, unfortunately, the left ventricle is still contracting like it's supposed to. So now you've got blood that's shunting across the pulmonary artery, or from the ductus into the pulmonary artery. It's making its way out to the lungs. And then it's returning like it's supposed to through the pulmonary veins. And now it's fully saturated. So it went out, it picked up oxygen, it's fully saturated, and it returns back to the atrium. Now, once it passes the left atrium and makes its way into the left ventricle, they made it purple here, but really, it hadn't really mixed yet, but we're going to just go with it because it's kind of like all happening all at the same time anyway. As soon as valves are opening and closing, things are starting to mix. So what's going on is the blood leaves the left ventricle, and now it's making its way into the pulmonary artery. But as it makes its way into the pulmonary artery, it's going to mix with this blood that's shunted across the ductus arteriosus. And then this is definitely, again, going to be purple. So without that foramina valley, so some of that blood, as you see, just literally shunts across the foramina valley. But for the rest of it that makes its way into the left ventricle and out into the pulmonary artery, it's going to mix with that blood that's shunted from the aorta into the pulmonary artery. So again, without the foraminal valley, this would be like just a where would the blood go? I mean, it would have nowhere else to go. It's just almost like a circle. So it goes into the pulmonary artery, into the lungs, back from the lungs into the left atrium, left ventricle, back into the pulmonary artery, back to the lungs. So it'll just be like literally a cycle. And again, the baby would not survive at all. So this ductus has to be open here, and then definitely the foraminal valley has to be open to at least get some oxygen to the body. And again, it's still not the best because it's going to be pretty desaturated. So notice that it says here that if there weren't some type of shunt in place, like atrial septal defect, VSD in some cases, or your PDA, then there would be no chance of survival otherwise. This picture here doesn't represent a VSD because, again, VSD is not natural. It wasn't one of the natural shunts that the baby had or the fetus had in utero. So that will be, again, kind of like another issue on top of the TGA. If they had TGA and a VSD, then we know that definitely something went wrong with the ventral septum as well. But ASD, as we know, is the foraminal valley, and PDA is just that, it's the ductus. Now, because of this constant mixing, they're always going to be cyanotic, always. No matter what, they're going to be cyanotic. And when you do an x-ray, here's another thing they want you to associate with TGA on x-ray is the classic egg, kind of like hanging on a string kind of thing. The entire heart looks almost like this egg. And what do we do for them? Of course, they're going to need some help. There's always going to be refractory hypoxemia. So we're going to have to use, of course, our ventilator settings, PEEP, as we need to help out that ductus by giving the prostaglandins to make sure that it stays open. Because if that ductus decides to try to close on its own, then it's going to be a problem for the TGA. And then surgery, and which case they're going to have to go in and switch things around and make it normal as far as the aorta connected to the left ventricle and the pulmonary artery connected to the right ventricle. So now, again, don't worry about those others like the truncus arteriosus and the PVR, and I'm not PVR, the PAV or TAVPR, and et cetera. Don't even worry about those because they're pretty rare occurrences that you don't encounter on a regular basis anyway. So then this part here talks about monitoring. And so what is it that we could do to kind of keep track of what's going on? So standard things we know, like blood pressure, we want to keep track of what's going on with the blood pressure. So an A line or an arterial line would be very helpful. If it's a newborn, we're talking UAC or umbilical artery catheter. And then CVP would be helpful to kind of see what's going on because a lot of these issues are going to cause way more blood on the right side of the system than normal. And then that could lead to a lot of problems, as we saw. So with, again, a newborn, we monitor their CVP usually with the UVC or umbilical vein catheter. And then cardiac output, if you don't have a non-invasive way of monitoring it, then you would have to have a pulmonary artery catheter to keep track of what's going on. The pre and post ductal pulse oximetry, again, is kind of like I wouldn't say it's a standard, but it's just so easy and so common to set up just 2 pulse oxes to detect whether or not the ductus is open or closed. And then end-tidal CO2 says here this is the best practice. So we're looking at a non-invasive way of keeping track of the CO2. And what I included here was this is just to show you you can have CO2 monitoring with someone who's not on the ventilator. So this happens a lot where you're going to have someone who just needs to be monitored closely, especially say someone has just had surgery, and you want to make sure that their CO2 levels aren't rising and that they're hypoventilating. So this right here, this is a side stream method. And all that's happening here is this little, here are, of course, the prongs, and this little tab right here that fits right over the philtrum. This is where one side is going to be delivering the oxygen for sure, but it all depends on how they have it set up. But one side will be delivering the O2 for sure. And then as the patient is exhaling, the CO2 will be sampled. And then this right here, you can't see the entire part of it, but this is the part that connects to the machine, and this is where the CO2 will continue to make its way through, and it'll make its way into the machine, and then the machine will measure how much CO2 there is. So it's more or less, it's just a nasal cannula with this extra extra attachment that is going to be responsible for sampling the CO2. Okay, and of course, just as a visual, here is a CAP monitor, and looks like right now the CO2 is being measured at 39. But just remember that this is non-invasive. So this is just saying that anytime you monitor something non-invasively, it's not going to be very accurate, or it's not going to be the exact as your invasive methods. And because we're looking at CO2 this way, that 39 could really be anywhere from, say, like 41 to maybe like 45 or 44. We don't really want to have a discrepancy of more than 5 between the two. So anytime you start CO2 monitoring, you start with an ABG to see what the CO2 really is. And let's say the CO2 is 40. And then once you connect your end-tidal monitor and it starts to give you values, you want to see somewhere between about 2 to 5 difference between them. Anything more than 5 it's not a good idea to use that device to trend with, because you don't know exactly what's going to happen, because that 5 or greater than 5 difference between the Petco and the Paco could be a whole lot more over time, because this device is probably it just needs to be recalibrated. But if it's working the way it's supposed to, it will be pretty close. It'll be somewhere around the neighborhood of, like, again, around maybe 2 to 5 difference between those values. And transcutaneous monitoring, this really works very well for babies because we know their skin is still pretty thin for the most part. There's not a lot of muscle. There's not a lot of extra layers of tissues and things like that, which makes them really good candidates for transcutaneous monitoring. And the principle behind this is you just need to have some means of heating up the skin in that little area. And if you heat up the area, then that will improve blood flow. So you got more blood flow right there where the sensor is attached to the skin. The greater blood flow would mean that now your gases should be able to diffuse across out of the capillaries and through the tissue, and then gets picked up by the sensor itself. So if you're going to be monitoring both O2 and CO2 non-invasively in this manner, and this is just called TCOM for short. Transcutaneous O2 monitoring. This is what we mostly are using these devices for, is to keep track of the O2. And then for CO2, we'll probably be doing the Petco. But if you don't want to have two different systems or two different devices in place to keep track of the CO2 and the PO2 non-invasively, these machines will give you both results. You could have both of them displayed at the same time if it's that type of machine. Most of them will do both. Some of the older models will only do one of the or the other, or it may just only do O2 and that's it. If you have one of those, then you're going to have to now definitely consider using something to measure Petco. So in order to do monitoring for CO2 and PO2 inside, there has to be two electrodes. And one being the Clark and the other being the Severinghaus. Clark electrodes are always meant to measure PO2, and the Severinghaus are going to be used to measure CO2. These are tiny little electrodes. They're the same electrodes that the blood gas analyzers are using, just on a very, very, very small scale. Now, where do you place one of these sensors on the baby skin? So because it's a heated system, you don't want to keep it in one place for too long. You run the risk of causing the skin to become irritated, or even some cases burn the skin. You think about like the really, really, really small babies who are very premature. So your policy will let you know just how often you're going to need to replace or reposition that sensor. Sometimes they may want you to do it every couple of hours, or maybe every hour, It's just going to really depend on your policy. And these are the acceptable places. So in the best, good, and fair. So all of the ones, of course, are the best place. So you're thinking never place it over like a bony prominence. You don't want to place this thing like right on the spinal column. And you don't want to place it like right directly over like the rib per se. You're kind of like trying to focus on like the area where there is tissue. Like there's definitely like muscle tissue or like adipose tissue. So that's why we think, say like at 8 o'clock, let's say your facility is saying that you got to have these things repositioned at least every 2 hours. So at 8 o'clock, it maybe started out here, and these are just like little sticky kind of things. They're just gonna like just stick it on the skin. I mean, you go through a calibration process each time that you place it on the skin. And I included a video in this week's material so that you can kind of see what that process looks like or what's involved with that process. So we may start off here, and then you go back at 10 o'clock. You peel it off, you recalibrate the sensor quickly with the device, and then you maybe now place it over here. But let's say that this area is still red, then no brainer. You're not going to take it and place it right back on top of an area that looks like it's already red. And then you may want to consider placing it here or here. And then 2 is saying good. I have never, ever seen anybody use the baby's forehead for one of these transcutaneous sensors. But it's, it's acceptable. It's just like you probably really don't want to. And I just keep going back to what about the really, really small micro preemies? Some of them are so small, there may not be enough room on their forehead to place one of these sensors. And then 3 is saying fair. These are fair areas that you can consider, like the thighs. The thighs work really well. I don't know why they considered it to be fair, but anytime that you do have to place one of these on the thigh, it usually picks up pretty well. And then, of course, the back, just stay away from the spine, and you're usually okay. So not only are you doing this to protect the skin from possible, burn or, irritation and things like that, the same would go for the pulse ox sensor. So with the pulse oximetry, I didn't include a picture here, but when you think about the pulse ox sensor, the pulse ox probe, the disposable ones, the ones that wrap around the finger, but in their case, you're going to be wrapping the entire thing around their hand. And so you'd have to kind of like do the same thing. You don't want to keep the pulse ox on one hand for too long. You're going to want to probably, as you're changing your transcutaneous monitor site, you're going to need to change your pulse ox as well. So if you start off with the pulse ox sensor wrapped around the right hand, then the next time you go in and just place it on the right foot or left foot or whatever the case is. So you're just trying to rotate that as well. Now, pulse oxes, when you think about it, they shouldn't really cause too much problem with the skin, but there have been cases where a very small, very, very small micropreemie has experienced some skin burn based on related to the pulse ox probe or the pulse ox sensor. So your best bet is just always just try to keep things moving and keep it in different areas of the body. Now, as far as troubleshooting, a lot of times if this machine is not really working like it's supposed to, this little part right here, well, sometimes it just needs to be recalibrated, and there's a little part right here, at least on this model, where you'll place the sensor here and then tell the machine to calibrate. And then you'll try again and see what happens. If the baby has poor perfusion, then just like with pulse ox, you're probably not going to get the most accurate results if you get anything at all to read. And what if the numbers are, again, just not really that accurate, and you know they're not that accurate? Then it might have something to do with the temperature setting. For O2 and CO2 monitoring, the manufacturer would recommend that you set the temperature on the device at, say, like 42 degrees or 44 degrees if you're going to be monitoring like CO2. But because these machines can do both, most times you're going to just focus on just like one temperature setting. Like just say like this particular brand, whatever manufacturer this is. Let's say that they tell you that you should have your temperature set at 44 degrees. And for whatever reason, you end up setting it at 40 degrees, then that could be a, a pretty good reason why your numbers are not that accurate. And it would probably look like the PO2 is a whole lot lower than what the PO2 really is. So then you'd have to just simply go back and just make sure that you have it set at the right temperature so that you do get the area adequately heated so that you get your gas diffusing across into the sensor like it's supposed to. All right, now, and then one other thing that sometimes would be odd. What if your PO2 appears to have just went from, say, before you were monitoring, it was like PO2 is around 60. Then you go back later and the machine is alarming because the PO2 is like over 100. And you didn't make any changes. You didn't make any changes to the baby's FiO2 at all. And there's no way that your PO2 should be able to just jump from like 60 to well over 100 like that. So then it could just be the sensor. You may have to just check and make sure that it's still on the skin, because sometimes if the adhesive isn't sticking like it's supposed to, then it'll start to come off. And now the sensor is, instead of measuring the tissue oxygen, and now it's measuring the room air oxygen levels. And that could be what's now causing it to kind of like read really crazy high numbers. And that would, again, usually be an easy fix. Just find another adhesive or find another area of the body where you've got good sticking, will actually stick or adhere like it's supposed to. Now, what's going to be your challenge with getting these things to stick on the skin? Some of the really small micro preemies, they're so premature, their skin hasn't really fully finished developing yet. So to protect their skin, they slather a layer of what's called like aquaphor on them, all over their bodies. And then they'll usually place like a plastic sheet over them, like a clear plastic, to kind of help them to conserve body heat, even inside of the incubator. So you got the incubator going, and then you also have them covered in this plastic covering to help them with their body temperature. And so if they've got all this aquaphor just slathered all over their bodies, now that's going to present a challenge for your transcutaneous sensor, your transcutaneous monitor. So you just have to kind of like find an area or maybe clean that area and as best as possible, so that way that the sensor will stick. All right. So now, questions. Which one of these is going to dilate your pulmonary vessels? Yeah, so O2 is always your pulmonary vasodilator. So that's the natural thing that happens with that first breath. In utero, there was very little oxygen, which caused a higher PVR. But once you now take the first breath, that oxygen will act to dilate those pulmonary vessels. Which one of these will be the most common? So would we give a PGE? Yes, we would. So think about it. In utero, the placenta was producing a lot of these prostaglandins. And that's what was helping to make sure that that ductus is open, that it stays open. So anytime that you want to get the ductus to open again, you got to be thinking more prostaglandins, more than the body's naturally producing outside. Now, which is necessary in HLHS? So for sure, in the reading, they mentioned something, I think they focus more on the ductus, but really your foramen valley would help as well when you got the HLSS situation going on. But here, if you got to choose as far as which one would definitely be necessary, then it would have to be your ductus arteriosus, because this is like again, HLSS could be one minor problem or it could be multiple problems that's affecting the left side of the heart. So with that, if you want to keep the blood flow about the same, then you're going to need to have a means of getting from the left side back to the right side. Now, we didn't talk about the baby that's having a TET spell. So there's a table, there's a box in the section that talks about the TET spells, and there's multiple things that we can do. We could do, of course, we could do the knee to chest. We could do morphine. We could do O2. We could also do beta blockers. Beta blockers and systemic vasopressor, systemic vasopressor. And bicarb. So there's many things that could cause a child with TOF to start having one of these TET spells. Now, usually they're not blue. But let's say the baby gets really, really fussy and starts really crying a lot. Then they start to get really blue and they're having this TET spell. Or like an older child, they're fine and then something happens and they something stimulates something, and then they get one of these TET spells, and then they'll tell them you could just do like just knee to chest kind of position, and that will help to increase your systemic vascular resistance. Because in a TET spell, you end up with like a right to left kind of shunt kind of a situation. So if you want to kind of get things back to where they were, then you'd have to find a way of getting your SVR to become higher again. So that's why, again, these like systemic vasopressors would do the job very easily because they're going to cause an increase in SVR. All right. And here's an analogy. Egg is to TGA as boot is to TOF. Is that true? Slide 11 says foramen valley for systemic perfusion. What is that? I don't follow. Are you talking about the previous question where we chose the ductus arteriosus? So if that's what if that's what you're referring to, remember I said that it did mention that both of those are going to be necessary, but with that kind of question, which one of those is definitely going to be necessary? So it kind of it didn't say which is the definite, but when you're having to choose between two things that can be acceptable, sometimes one is going to be a little bit more than the other, or a little bit better than the other. So that's another challenge that you're going to have sometimes, unfortunately, is when they give you questions where two answers will definitely work, but which one are they wanting you to focus on the most? And it's not right, but it's done all the time. I mean, they test you like that just to kind of to see if you really can find something about one over the other that makes it, or it kind of like tips the scales just a little bit more in its favor than the other. Yes. Yeah, again, and remember, these slides are, and they're like an outline. You've got to go back and read. You've got to. I have to read this stuff. And I can't cram everything onto the slide because that would defeat the point of what a slide is supposed to do. So a slide is supposed to give you like an overview of the information. Then you go back and read to see what the author really had to say about this stuff. All right, so this one is a true analogy. You expect to see like the X-shaped X-ray when there is a transposition of the great arteries, and then the heart on the tetralogy looks to be kind of like a boot. Where can we place the preductal pulse ox probe? Yeah, so anywhere on the right, like if the finger's big enough where you can wrap it around the finger. Usually their fingers aren't that big to be trying to wrap this thing around. So you're going to use usually the entire hand. And that's pretty much this chapter. So now for what we have. So just again, there's midterm quiz 2, and then there's reading quiz 1 that they both need to be done before midnight tonight. Tomorrow we do the exam, and then we get into chapter 17, but we're not going to finish chapter 17. Even if I just ran through it without like stopping, I don't believe that we would get through the entire chapter after we've done our test. And that just means that, we had to sacrifice because we have to do our checkouts on Wednesday. So we got a day that we lost for instruction being on campus. And when we do our checkoffs on campus on Wednesday, just know again, because of the sake of time, there's another reading quiz that will have to be done before midnight that night. And then when we start back on Thursday, the non-invasive CPAP and that stuff, chapters 15 and 16 is not that much information. So luckily we can continue where we leave off on chapter 17 on Thursday, finish that, and then we can get into chapter 15 and 16. And as you see, that'd be your final midterm quiz. So this class is coming to an end pretty quickly. And these are just all the things that now we got to try to get done before the end. So that's all that we have for today. And again, just use the rest of this time to complete your assignments or work more on your final project. And that's all, unless you have any questions. I have a faculty meeting today at 2:30, but